Welcome back to the Explainer, everyone. I am absolutely thrilled today because we have finally reached the grand finale, part 15 of our comprehensive masterclass on myocardial infarction coding. Just think about how far we've come. We started all the way back at basic cardiac anatomy, we worked our way through the tricky pathophysiology of ischemia, and today we're tackling MINOCA, old MI guidelines, and some vital coding addenda updates.
Here's a quick look at our roadmap for this final explainer. First, we'll dive into MINOCA and code I21.B. Then, we'll look at coding an old MI, walk through some crucial guideline updates, and finally, we'll wrap it all up with the masterclass mega recap.
All right, let's jump right into Section 1, MINOCA, and code I21.B.
So let's look at a really fascinating scenario. An acute MI that happens without any mechanical or atherosclerotic blockage in the epicardial coronary arteries. This is MINOCA. Basically, instead of a blocked main artery, this whole condition is driven by coronary microvascular dysfunction, microvascular resistance, or even vasospasm. The heart muscle is literally still starving for oxygen, right? But the plumbing issue is happening entirely at the microscopic level.
When you're looking at this specific clinical scenario, you absolutely must assign code I21.B. That stands for myocardial infarction with coronary microvascular dysfunction. This code explicitly includes MINOCA with microvascular disease, giving us that exact clinical specificity we need to properly capture these unique, non-obstructive cases on a patient's record.
Now, it's super crucial to understand how this has evolved recently. Historically, back in the second quarter of 2023, coding clinics advised defaulting to I21.4 for an NSTEMI when dealing with MINOCA. But as you probably know, things change. The fiscal year 2024 update, which went into effect on October 1st, 2023, established I21.B as the specific dedicated billable code. You've got to use this updated code to stay accurate and fully compliant.
Moving right along to Section 2, coding an old MI, specifically code I25.2.
Okay, so code I25.2 for an old myocardial infarction is fundamentally a history code. It essentially tells the story of a past MI that's older than 28 days. It's often diagnosed on an ECG or some other investigation, and the patient currently has zero active symptoms. But here's the catch. It's a bit of an anomaly, honestly. Why? Because it lives in the I25 category for chronic ischemic heart disease, sitting completely outside that traditional Z-code chapter where we normally expect to find all our history codes.
Because of that unique placement, there are some pretty strict rules to follow. You only assign I25.2 as an additional code when it has distinct significance for the current episode of care. On the flip side, do not assign this code when current active ischemic heart disease or an acute MI is actively being managed. Basically, you really have to evaluate the current clinical picture to decide if this historical fact actually impacts what's happening with the patient right now.
Next up is Section 3, Guideline Updates and Addenda.
As we all know, clinical coding is literally never static, and that brings us to the significance of mid-year and annual addenda updates. Just as an example, the April 1st, 2024 updates introduce some really vital refinements to terminology and addenda revisions. If you're relying on outdated codes or missing these kind of incremental shifts, you're opening the door to immediate compliance and revenue risks.
Honestly, staying current with these continuous updates is the only surefire way to ensure clinical documentation integrity and protect the healthcare revenue cycle. Make it a solid habit to actively review these addenda the second they're published by the official governing bodies. Remember, precision in coding isn't a one-and-done thing. It's a continuous, year-round practice.
And now we've arrived at Section 4, the Masterclass Recap, the Mega Recap.
Let's build your ultimate clinical coding cheat sheet from the ground up, right here, right now. Remember where we started? With foundational anatomy, mapping out the precise arteries involved in STEMI and NSTEMI events. Then, we categorized MI types 1 through 5 by their specific clinical drivers. Everything from spontaneous plaque rupture to supply and demand ischemia. After that, we navigated those strict 4-week time frame rules for subsequent MIs. And today we topped it all off by adding MINOCA, utilizing code I21.B for microvascular dysfunction, and clarifying that an old MI is only ever coded as I25.2 if it directly impacts current care.
It has been an absolute privilege guiding you through the intricate, sometimes crazy world of myocardial infarction coding over these 15 parts. Your dedication is exactly what ensures the highest standards of CDI compliance and perfectly accurate patient records. But as we know, the medical field is always evolving. So ask yourself, are you prepared for the next major coding update when new cardiac technologies emerge? Keep this knowledge sharp, keep asking those great questions, and as always, decode healthcare with Harshal.